I'm asked to talk about the single operator cholangioscopy today. So I'm going to share with you some of its use in the management of indeterminate biliary strictures and difficult bile duct stones. So for modern cholangioscopy, we can perform with a two-operator mother-baby system or a single-operator system such as the SpyGlass, or a direct per-oral cholangioscopy by the ultra-thin upper GI endoscope or the new multi-band cholangioscope. So the mother-baby scope actually is a very good system. It's a two-operator system. It provides excellent image quality with NBI capability. And recently, Olympus has launched a new 290 baby scope, and I think they're trying to improve the durability of the scope, because in the past, I think people have to be very careful with the scope because it's a delicate device. So as you can see in the picture here, we have one expert endoscopist holding the scope, and it has a two-way deflection, and you need to use torque to turn around the corners. And then you have another endoscopist holding the duodenoscope there. And as you can see, this patient has a stricture due to cholangiocarcinoma, and it shows excellent images on both white light and the NBI view. So for the single operator cholangioscopy system, so the advantage is that it requires only one operator. But in the beginning, because it is a fiber optic system, so when you first use this optical fiber, then the image is quite nice, but over time, the image quality may degrade. So nowadays, we are into the second or the third generation with a digital system, like the digital SpyGlass DS and the DS2, and it has offered improved image quality, such as what you see here, and it's very easy to use. It's kind of like a plug-and-play system. So it's definitely relatively less technically demanding when compared to the mother baby system. And of course, if you really want to have a scope with bigger channel size for therapy and also probably the best image quality, you need to perform cholangioscopy with an ultra-thin upper GI endoscope or multi-band cholangioscope here. Again, it could be technically challenging to insert this scope per orally, but again, with the new multi-band scope, I think they're trying to improve on the ease of bile duct cannulation. And as you can see in the table here, the ultra-thin multi-band scope actually has a more tapered end than the XP290N scope. So we'll be happy to see more data coming out for the utility of these scopes. And so far, we have seen a randomized study reporting a good performance of the multi-band scope. So today, we're going to focus on the single operator system. And I think everybody will encounter some of the situations like what we're going to talk about here, the so-called indeterminate biliary strictures. So what are these? So basically, indeterminate biliary strictures could be strictures that has already gone through ERCP and probably brushing, but then we still have inconclusive results regarding this nature. And in meta-analysis published in 2015, so we can see that the brush cytology sensitivity and also the intraductal biopsy sensitivity was quite suboptimal, maybe both in the 50s range. But if you combine them, well, you get a little better, probably up to 60% of sensitivity. But again, we want to see a better result than that. So there's always a need for a better system. So now this is a landmark paper by Professor Yang Chen, published in 2011. This is basically a large prospective cohort study of 290 patients from 15 centers in USA and Europe using the fiber optic SpyGlass DS systems. And as you can see here, complete stone clearance can be obtained in 1 SOC session in 70% of cases. And the diagnosis of indeterminate biliary strictures for malignancy, the sensitivity is up to 70% for visual impression, and for SpyGlass directed biopsy, the sensitivity is around 50%. And the rate of serious procedure-related adverse events were quite low, and I think they're quite reasonable when we're talking about these complex procedures. So now we also have data for the digital SPY. So this is also a landmark paper published by the Florida group by the Rockhorse group in 2016. It involves 105 patients, including both cholangioscopy and pancreatoscopy, and most of these patients underwent management of bile duct stones. But also for patients with intraductal stricture, they found that the visual impression is very helpful. The sensitivity for malignancy is up to 90%, and with a very high sensitivity for the SOC guided biopsy sensitivity up to 85%. So this is quite remarkable. And also, again, good results for management of difficult stones, good stone clearance rate in one session up to 86%. So let's take a look here. This is a video demonstrating what we can see with the digital SPY and the use of SpyBite in the cholangiocarcinoma. So now there's a mid-duct stricture here. So we're using freehand cannulation technique here. So there's a sphincterotomy. Now we're just putting the tip of the SpyGlass up, and then we're trying to cannulate by freehand. So it's going up quite nicely. So now this is what we can see. Now definitely we're seeing better images when compared to the fiber optic system. Now, so here we see a stricture due to a nodular circumferential mass. Now a close-up can show us the obvious irregular tumor vessels. So this is clearly a malignant stricture by visual impression, but again, we want to proceed to SpyBite biopsy here. So some nice images. So here's a SpyBite. Now this is the original SpyBite. So now you can see the kind of tissue that you can get from here now. So a bite is being taken off. But again, we recognize that in real practice, we're not always that lucky to get a diagnostic tissue. So, but now let's take a look at this case. So this is interesting. So patient has known metastatic lymphoma and suddenly developed bile duct stricture. We don't think it's liver injury from chemotherapy. And on ERCP, we saw stricture. To our surprise, on SpyGlass, we see this friable frondy material here. So we're worried that, well, is this second primary cholangiocarcinoma, or is this intraductal involvement by the lymphoma? So again, I think visual impression shows a malignant stricture, but I think we need tissue to guide the next step, because if this is lymphoma, I think patients should get further chemotherapy. So again, we see some irregular mass with tumor vessels. And then let's see, okay, now we have a SpyGlass coming out and then getting tissue there. So, and this turns out to be a case of lymphoma. Okay, so now this is another interesting case. So this patient has recurrent cholangitis. This patient has recurrent cholangitis, and we didn't find stone, and instead we saw a bunch of mucus coming out from the papillotomy. So we decided to go for SpyGlass, and so what we found inside was quite a cloudy view due to the mucus. Now here again, freehand cannulation. Now we are in there. A bunch of mucus was seen. So we end up having to infuse some mucolytic to see what's going on. And afterwards, we start to see this papillary projections. So this is a case of IPNB. So we also proceed to SpyBite biopsy, and the result was diagnostic for IPNB. So we see some beautiful images of IPNB here. Okay, so just now, Torsten has mentioned RCT with collaboration from EVK, PWH, and also AIG. So this paper was published in this year, and this is a randomized trial comparing digital SPY, visual impression plus SpyBite biopsy versus traditional ERCP, cholangiography, and brushing. And well, with this study, we see that the visual impression again is performing very well, but again, the sensitivity of SpyGlass directed biopsy was less sensitive than what we have seen in Rockhouse group. So we are thinking that, well, maybe this is more real world data because this is from 3 different centers. But again, I think the take-home message is that we still need to get better devices for biopsy. So can we do better? So nowadays, we have access to the new design of the SpyBite, the SpyBite Max biopsy forceps. It has some jaws on the cuff of the forceps. And let's see in this case whether this will help us to get better sample. So this is a case of IgG4 cholangioscopy after steroid treatment. But again, there's still a stricture in the mid-bile duct. On US, there is what looks like a mass there. So relative stricture on ERCP, now definitely not as tight as before. And this is what we saw. Interesting flower-like lesion next to the takeoff of the cystic duct. Now, it doesn't look very malignant, but again, we'll use the SpyBite Max to see what we can get from here. This is SpyBite Max. I think the grab is quite nice. And we're going to show you some histology to show you what kind of tissue we get. Now, feels pretty good when we take the bite off. Now, this is what we get on 40x. This is 100x. And it is a diagnostic specimen showing that this is chronic inflammation. And with IgG stain, it's positive, but because this is after steroid therapy, the IgG4 positive plasma cells has markedly decreased. So I think this is quite promising. So moving on to difficult bile duct stones. So again, there are some definitions for difficult bile duct stones here. So basically stone bigger than 1.5 centimeter, or impacted stone, or barrel-shaped stone, or stone duct size mismatch, or stone in intrahepatic duct or cystic duct. So now with the ESG guidelines, now it's not bad to attempt the procedure for lithotripsy by basket mechanical lithotripsy, but sometimes we do get into trouble. So now, on a good day, we can do a papillotomy followed by a large balloon dilation. Maybe we can use a BML, and then we get the job done. But then, now, there are days that, you know, things don't go well. You got a big stone, you got a good capture of the stone, but it doesn't crush. And then we end up with a trap basket. So yesterday, we saw a case of trap basket, nicely rescued by Professor Lau's procedure. And patient has been doing well, actually no pancreatitis, so it's a great procedure. So here, now we can see what the SpyGlass can offer. So big stone, got the SpyGlass up, and then got a stone here. We have a laser ready to fire. So in our unit, we are using the Homium Yak laser. So now we start to see fragments. So we're going to flush it with water, and then we're going to see this. Now, instead of just burning a tunnel, this one, we're going to see some real fragmentation of stones here. So some nice fragmentation, and then we can achieve clearance in one session. So nice fragmentation of stones. So now, Here, this is RCT published by James Buxbaum in University of Southern California in the United States. He used the fiber optic system, but what he can demonstrate that SPY can help us to achieve good stone clearance versus conventional therapy. And then CUHK has also published our experience here. So the initial experience of SPY DS in 17 patients. So we're tackling some big stones up to 2 centimeters or even 4.5 centimeters at some cases. We have good results. So so far, overall stone clearance is more than 90%, and mean procedure time is about 90 minutes. And we have adverse events rate of 12% due to cholangitis. And we also have data that is published by the AMNS registry involving a lot of centers, published in Endoscopic in 2019, and again confirming the efficacy of SPY DS in management of difficult stones. And I think this probably is the way to go, and we could avoid some mishap with the BML. So can we do even better? Now we may be able to group some of these fragments with the SPY retrieval basket. So dear ladies and gentlemen, so I hope in this lecture we have shared with you some of the experience on using SPY DS. I think it's a valuable tool for management of indeterminate biliary strictures and difficult bile duct stones. We have seen good results. I think with improvement in the accessories for the SPY, I think we may be able to do more in the future. So thank you very much.